Hello, I'm Professor Trevor Duke and I'm a pediatrician. And this is a series of lectures on uh, the World Health Organization Pocketbook of Hospital Care for Children guidelines. WHO in 2020, 2005 published a book called the Hospital Care for Children, Pocketbook of Hospital Care for Children. The second edition was published in 2013, and the third edition is currently in the pipeline. It's a book of guidelines for the management of common illnesses in children at all levels of the health service, but particularly at a district level hospital where non-specialist doctors or pediatric nurses or pediatric registrars in training may be managing seriously ill children. It's also relevant at a secondary referral level hospital where there are pediatricians, and it's relevant too at a tertiary level hospital. I think if all hospitals implemented these guidelines, then the quality of care would be substantially better. The WHO's Pocketbook of Hospital Care for Children comes with some teaching modules, and I'm going to go through one of the teaching modules today on malnutrition, on the chapter of malnutrition, which is chapter 7 in the Pocketbook of Hospital Care for Children. There are other teaching modules online going through other chapters in the book, and you can watch them as well. As well as the guidelines themselves, the pocketbook and teaching modules, there are other tools that the World Health Organization has to support improving the quality of care for seriously ill children, including guidelines on morbidity and mortality auditing, which was published in 2019, and guidelines on the clinical use of oxygen in children, which was published in 2016, and many other resources that WHO has. I'm going to share my slides now and then we'll start. These teaching modules are designed to go through a case and teach healthcare workers how to look after sick children using the Pocketbook of Hospital Care for Children in everyday clinical practice. So how to navigate and use the book in everyday clinical practice. As I said, this teaching session is about malnutrition, and there's because of the primacy of malnutrition in the world, its relevance to child morbidity and mortality. There's a whole section on the management of malnutrition, mostly based at a hospital level, but also obviously the management of malnutrition also occurs at a community level. So we'll go through this. It's a case-based teaching module, and we'll go through the case and try to use the book to manage the case that's discussed. This is Kobe. He was a little 12-month-old boy who was brought to a district hospital from a rural village by his mother, Uma. He presented with an 8-day history of loose, watery stools and a two days of increased irritability and poor oral intake. He wasn't able to drink at all. And you can see him there. He looks a very sick baby, doesn't he? He looks very sick, and you can see some other aspects about him. Often when a child presents to a clinic or an emergency department, that's all you know about the child to begin with, but you can make an assessment. Now, as we've been going through these teaching modules, we've learnt that it's important to have a systematic approach to the management of seriously ill children, and WHO has recommended an approach that has 10 stages of management, and those 10 stages of management in any sick child include triage. All hospitals, all clinics should have some system of triage so that children don't have to wait excessively long when they're very unwell. Triage is a form of sorting of patients. It's sorting out those that have emergency signs from those that have priority signs, and those who have neither and can wait a bit longer. Remember, if you find an emergency sign, then you should stop the the process of assessment and then give emergency treatment immediately. If there's no emergency signs, then move on to priority signs. If the child has priority signs, then they should be seen promptly. And if they have neither of those, then they can wait because they're not as unwell. So triage and then giving emergency treatment if needed, and then taking a more thorough history and doing an examination. All we know from the presenting complaint at the start was simply that the child had been unwell for 8 days with diarrhea and 2 days with poor feeding and irritability. But there's obviously more to the story, even just looking at Kobe, than simply that. So taking a proper history and doing an examination, and then doing some laboratory investigations if needed. And in many children, laboratory investigations are needed to explore, to confirm a diagnosis, to exclude other diagnoses, to look for complications of the underlying disease, the primary diagnosis, or some other secondary diagnosis, to look for comorbidities, um, etc. But mostly these investigations are very basic investigations that are required, and mostly can be done at a district level hospital. And for many sick children, no investigations are required because you can work everything out based on history and examination. Then you come up with a main diagnosis and other diagnoses. Remember, I said they could be either a differential diagnosis, alternatives, or it could be comorbidities, something else the child has. And we'll see in Kobe the number of diagnoses that he has. And then decide on the treatment. Just again, going back to the diagnosis, to come up with that, you have to triangulate the concept of triangulation of all the information you have at this stage. That is the information you get from all the previous stages at triage. You get some information about the severity of illness of a child. You get information from the history and the examination, and you may get information from laboratory investigations if you need to. And you triangulate all that information to come up with a diagnosis or other diagnoses, and you can use the book to do that. Then you decide on the treatment. Again, that's the standard treatment for common illnesses is included in the book. And then there are four other stages of management that when we looked at hospitals throughout the world, we realized that while making a diagnosis and giving treatment are usually done fairly well, these stages, supportive care, monitoring, discharge planning, and follow-up, were done very poorly. And that really impacts upon quality of care. So this is triage, and we need to decide whether Kobe has emergency signs or priority signs. So what we knew at triage, you take the temperature and weigh the child. You take temperature because that's important to know whether the child's got a fever or otherwise, and also you weigh the child because any medications you might give as part of emergency treatment or ongoing treatment requires that we know the weight of the child. Secondly, you then pay attention to the airway, the breathing, and the circulation. And when you pay attention to the airway, it's just looking for emergency signs, obstructed breathing, and you might see that with a tracheal tug or a stridor or snoring breathing or severe respiratory distress with evidence of obstruction. So look for obstructed breathing. When you get onto B for breathing, look for signs of respiratory distress, so the respiratory rate, look for chest indrawing, look for tracheal tug, look for grunting, those signs of severe respiratory distress. Then in terms of C for circulation, airway, breathing, circulation, you feel the hands and feel the feet. And feel the hands to feel if the hands are warm or cold. Feel the peripheral pulses, so the radial pulse, or if you're feeling the feet, then feel the posterior tibial, that's behind the tibia, or the medial malleus, or the dorsalis pedis pulse, which is on the top of the foot. So feel the posterior tibial or dorsalis pedis pulse, or the radial pulse, and often I feel both. I feel the hands, feel the feet. If the hands are cold, then feel up the arm to feel how high the coldness goes. And then check the capillary refill time. If you do those three things, are the hands warm or cold? Are the pulses normal volume or not? Is the capillary refill time less than 3 seconds, 2 seconds or less, or more prolonged, then you'll know if a child's in shock. If a child's got warm hands and feet, if their capillary refill time is 2 seconds or less, if their pulse volume is strong, then they don't have shock. So Kobe's pulse volume was normal, and then lastly, look for their conscious level, airway, breathing, circulation, D for disability or conscious level, and check to see that the child's alert and interactive, or responds only to verbal stimuli, or responds only to painful stimuli, or is unresponsive to the AVPU score. There's other scores you can use, but at a triage level, that's sufficient. And you can do all of that within a minute or two of seeing a child. You can make that assessment in a short period of time. Kobe's pulse volume was normal. His capillary return was less than 3 seconds, and his pulses were strong, and his skin was cold. His saturation was 92%, and his weight was 6 kilos, and his length that was assessed at triage, that was 69 centimeters. So that's what we know from triage about Kobe, and 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 we can decide whether or not there's evidence of any emergency signs. He's got some signs of shock in that he's got cold limbs, but his capillary refill time is normal. He's got no obstructed breathing. He doesn't have severe respiratory distress. His respiratory rate is 50. So, and his saturation is 92%, which is a bit low, but not very low. And he's not cyanosed. So he doesn't have any clear signs, emergency signs that require urgent treatment, but he does have some priority signs. He's clearly, he looks pale. He's got a temperature that's not high, but it's actually low, isn't it? 34.8 degrees. And he's got evidence of malnutrition. Just to look at him, you can see that he's wasted and is malnourished. So even though he doesn't need any urgent emergency treatment, he does need very prompt treatment, and that requires him to be seen immediately, not necessarily to have any emergency treatment, but to have prompt assessment. So you would then take a more detailed history, and this is the history. Kobe was well until 5 months of age, or at least he was seen to be well. He was thought by his parents to be well. And at 5 months of age, his mother, Uma, became pregnant again. Uma had started to wean Kobe from the breast at 3 months of age because her milk supply was poor. At 4 months, she started formula milk feeding in a milk formula bottle with a rubber teat. And Kobe was given some solid foods from 4 months of age. So he was weaned early, and he was given some solid foods, mostly potatoes they grew in the garden and some vegetables. From 5 months of age, he had 6 episodes of diarrhea. Each lasted for about a week. So this is recurrent diarrhea that Kobe's had, and now he's 12 months of age. During each episode of diarrhea, his mother described how she often reduced the amount of fluids and feeding that he received because she thought it would reduce his stool output, his diarrhea. And on this occasion, he was sick enough to be brought to hospital as he'd become irritable and was, failing to drink or eat very well in the last couple of days. So that's the history. That's the history we have so far. On examination in the children's emergency department, Kobe looked very unwell. He was clearly wasted, and you can see from the picture he had very loose skin folds over his arms and his buttocks and his thighs, and he had visible ribs outlined. That's not severe respiratory distress with chest and drawing. That's just where you've got intercostal muscle wasting. His temperature was 34.8, so he's hypothermic, and that's a danger sign, isn't it? His pulse rate was 130 per minute. His respiratory rate, as we saw, was 50 breaths per minute. His weight and his length were measured, and his mid-upper arm circumference was 10.1. In a moment, we'll check what that weight and length actually means. His mid-upper arm circumference was 10.1. And for those of you who know this, the mid-upper arm circumference in a child of over 6 months of age and up to a few years of age should be, if it's less than 11.5, then it suggests the child has severe malnutrition. It's a good screening test for severe malnutrition, but you can be a bit more precise by assessing the weight and the length. So the weight for age and the weight for length. And if you use we'll do this in a minute, but if you use the tables on page page 386 and page 385 of the Pocketbook of Hospital Care for Children, you'll be able to see what Kobe's weight for length was and his weight for age. His air entry was normal on both sides of his chest, so there was no evidence of any major respiratory problem, although he does have desaturation. His saturation was only 92%, wasn't it? And both heart sounds were heard, and there was no murmur. His abdomen was sunken, you could see that, and his bowel sounds were audible, and his abdomen was very soft, mostly because you've got a muscle wasting of the abdominal muscles, so the abdomen feels often very soft. He looked dry, he had dry mucous membranes, and his eyes were sunken with no tears and dry conjunctiva. So you've got a child who's got significant dehydration, moderate, at least moderate to severe dehydration. He had prolonged skin pinch and decreased skin turgor. So really, we're now identifying perhaps that Kobe did have an emergency sign, and that was severe dehydration with sunken eyes, dry conjunctiva, dry mucous membranes, prolonged skin pinch, decreased skin turgor. So possibly Kobe had that emergency sign, which would require some emergency treatment, which we know we're going to do anyway, because he's a sick, very sick baby. He had no neck stiffness, but he was quite lethargic and moving his arms and legs to touch, and you can imagine how lethargic he was. This was his weight for age. If you look on page 385, you'll see the weight for age chart for boys, and his weight for age suggests that he's substantially less than -3 standard deviations below the mean. The weight for length is another measure, and it's said to weight for age can be low weight for age can be seen in children who have chronic malnutrition, and low weight for length is more seen in children who have acute malnutrition. I think either one is acceptable, and actually weight for age is something that healthcare workers, I think, understand very well. But Kobe's, if you go to the chart on page 386, you'll see the weight for length from birth to 2 years in boys. And to look at this chart, his length was 69 centimeters, and his weight was 6 kilos. And so when you look at, you start with 69 centimeters and then move across, and you can see what the 3 standard deviations, 2 standard deviations, 1 standard deviation, and what the median is. So the average weight for a child of 69 centimeters in length should be 8.2 kilos, and Kobe weighed 6 kilos. So that puts him certainly less than 1, certainly less than 2, even less than 3 standard deviations. So that confirms what we found with weight for age, that his weight for length was 6, is less than 3 standard deviations below the median weight for length for his length, the weight for his length, right? So if you have a stadiometer, a way of measuring length, then it's quite useful, especially if you don't know the child's birth date or their age. We knew that Kobe was 12 months of age, but perhaps that's not accurate. It might be a month or two either side, and his family are just unsure. Then weight for length becomes very important. But if you know the date of birth, then weight for age is just as good. And I think healthcare workers sort of understand a chart like this. We need to teach people how to plot such charts on a regular basis so you can do proper growth monitoring. The alternative, if you've got no date of birth or uncertainty about age, and if you've got a way of measuring length accurately, then is to do weight for length. So Kobe had clearly malnutrition, and in some ways malnutrition is a clinical syndrome, isn't it? You still need to decide what the underlying cause is. And most likely, based on the history that we have, his malnutrition, his wasting, what used to be called marasmus. If you look at the picture of Kobe, you look at the picture, he's got severe wasting, and you can see how loose the skin is around his legs. He's got severe wasting. We would previously have called that marasmus, and that's a bit different to kwashiorkor, where you've got edema, but we would have called this marasmus. It's similar to that. So his severe wasting was likely due to inadequate food intake, wasn't it? He was weaned early. He was started on bottle feeding. He had uh, well, it would be useful to go back and get a more complete nutritional history, and perhaps that's something you can do once you've done the initial assessment. His diarrhea was due to he had diarrhea, and that's associated with bottle feeding, isn't it? If families are formula feeding their babies, then there's several risks. One is that they might dilute it incorrectly and give a dilute feed with low caloric intake, with reduced calories compared with what's recommended. And two is that families who live in more difficult circumstances where they don't have normal, the standard, I suppose, optimal utilities like electricity or a stove that will enable sterilization of an infant feeding bottle, then they're likely that they may wash the bottle in just any water supply they have, and that might be contaminated. And also, if you leave some milk in the bottle, that's a very strong culture medium for bacteria, and so many families are unable really to properly sterilize infant feeding bottles, and that leads to bacterial overgrowth and then often bacterial diarrhea. Um, so there's at least two things we know. One is that he had severe malnutrition due to inadequate food intake. Secondly, he had diarrhea, most likely due to related to bottle feeding, but also potentially related to some other gastrointestinal infection. He could have had always consider whether he's got severe malnutrition due to some other disease like tuberculosis or HIV or malabsorption syndrome, celiac disease or whatever, or some other chronic disease, and whether and consider whether Kobe's got some micronutrient deficiency like vitamin A deficiency or zinc, which are like comorbidities related to severe malnutrition. Just consider those things. Don't most most malnutrition is related to poor intake and early feeding or early weaning and loss of an adequate milk supply, inadequate duration of exclusive breastfeeding or maternal ill health and poor feeding, and then inadequate complementary feeding in the next sort of 6 months of life, but not all, and some is due to underlying disease. So always be alert for that. So you might therefore go and ask further questions on history. Firstly, what his nutritional history was from birth. And when you're taking a nutritional history, you need to take in two ways. One is a longitudinal history, so the history of nutrition from birth. And the other one is like a cross-sectional history, which is on a typical day or a typical week, what would Kobe eat? And the two things are different. One is a longitudinal history, trying to understand the timeline of when he was, whether he was exclusively breastfed or whether he was weaned early, or when solids were started and what type of solids were started, and the quality, whether he was on a balanced diet, or the quality of the complementary feeding and how frequent he was fed. And then the other one is the typical foods that this child would be given on any given day or any given week. So a longitudinal history and a cross-sectional history. You might want to ask more questions about the type of diarrhea that Kobe had. We know that he had 6 episodes of diarrhea from the age of 5 months, but you might want to ask whether it was just watery, or whether it was bloody or mucus or pus in the stool, because it might help you understand what pathogens are likely to have been causing this. Of course, you'd want to know a bit more about the family circumstances and the home environment. You might want to ask about other things that might be associated with severe malnutrition, such as chronic cough from tuberculosis, or whether the child was exposed to measles or had measles recently, or some other infection that might have precipitated his severe malnutrition, and you might want to explore, think at least in your mind, whether or not it's possible he's got an immunodeficiency like HIV or something else that might be underlying his severe malnutrition. So this is Kobe's nutritional history. He'd been on formula feeding since 4 months of age. He was breastfed from birth, but on formula feeding since 4 months of age. And the milk was diluted, as I said, 1 scoop of milk per whole bottle of water. It's unclear, not exactly following the instructions on the can, because it's often a tin of formula is quite expensive. His mother would wash the bottles in water from a rainwater tank. So again, it's not sterilizing a bottle in boiling water, but rather washing from the community water source that they had. He was given weaning food at 4 months of age, and mainly, as we said, potatoes and vegetables that the family grew in their own garden. He would get meat or fish occasionally, but not in the last month. And Kobe usually receives 2 meals and 2 bottles of milk each day, sometimes 3. He sometimes has to share his plate of food with his older siblings. He had 2 older siblings. His family circumstances, his parents lived in a small wooden house, and he had 2 older sisters and 1 older brother, so three siblings. They had a small plot of land on which they grow crops, some of which they were able to sell at the market and get some money. And Kobe's father farmed the land, and Uma, his mother, worked as a housemaid where she could earn some more money for food. And because both of them were quite busy with their work, Kobe's older siblings mostly took care of him. And that's a common scenario, isn't it? When the families go out to work, the young children in the family are looked after by the older children, and that can be that can be difficult for them to be adequately fed. You might want to go back and do some further examination. I always think when I've first seen a child, even if you're spending 15 minutes with them to start with, taking a history, doing an examination, you can't find out everything you need to know. So you might want to go back and reassess the child for other signs of severe malnutrition, such as whether he's got severe anemia, whether he's got eye signs of vitamin A deficiency, whether any skin changes of kwashiorkor, or other signs of HIV, or we know he's got hypothermia, whether he had Mal's ulcers, and the degree of dehydration that he had. So Kobe's, if a child's got Palmer-Palla, it usually means their hemoglobin is less than 8, usually around about 6 or 7, or less. You should also check their conjunctiva and their mucous membranes for pallor, obviously, especially in a child with malnutrition. And the eye signs of vitamin A deficiency, firstly, the conjunctiva become dry, and we know that Kobe had dry eyes. And then sometimes you get a softening of the cornea, and ulceration of the cornea. And keratomalacia just means a very soft cornea, and you can see that sometimes there's erosion or ulceration of the cornea, which can lead to blindness. So very important, if a child's got severe malnutrition, we check for signs of severe of vitamin A deficiency and replace the vitamin A anyway. These are the signs of kwashiorkor or zinc deficiency. I mean, this, as you can see, there's both of these children don't look like Kobe. Kobe was wasted without edema, but sometimes you see children that are very edematous like this, and that's because they have hypoproteinemia and very low levels of protein in their blood, and they become edematous. And the skin changes are common in kwashiorkor, where you get, it's called flaky paint skin, where you get peeling of the skin and hyper and hypopigmentation. So sometimes darker pigmentation and sometimes lighter pigmentation of the skin in children with kwashiorkor. So you might want to do some investigations on Kobe that might assess the severity of his illness, whether or not he's got comorbidities, and exclude other conditions. So firstly, you would want to check his blood sugar and see whether or not that was normal. That could be done at triage in the emergency setting. You should check his blood sugar. He was irritable and lethargic, and you should check that You should check his chest X-ray to see that he's got no signs of tuberculosis, if you can do that. Kobe had a stool microscopy, and that showed trophozoates of Giardia, and Giardia is a relatively common infection causing diarrhea, and it often causes recurrent diarrhea because it doesn't necessarily clear from the gastrointestinal tract, so it may cause recurrent or chronic persistent diarrhea in children with severe malnutrition, particularly. And then during the during the admission, Kobe's parents agreed to having a test for HIV, and that was negative. So we know from this that he's got no evidence of TB. He's got not got HIV. He's got hypoglycemia, and he's got Giardia. So we're building up an understanding of this of the diagnoses that are present in this child. This was his full blood count. This is the real full blood count of Kobe. His hemoglobin was 6, so as we said, he's got Palmer pallor, so it means his hemoglobin is going to be less than 8 grams per deciliter. His white cell count was 2.6, so it is not high. It's actually low, isn't it? And his neutrophil count was a bit on the low side too, not high. It was on the lower limit of normal, and his lymphocyte count was also low, which those things, leukopenia, neutropenia, lymphocytopenia, low levels of those white cells, and not. It's quite common in children with severe malnutrition to see that a suppression of their bone marrow because of undernutrition. His platelet count was normal. His mean cell volume was 60, and you can see what the normal range is, 78 to 97. And that suggests that may have iron deficiency anemia. So his MCV is low and his hemoglobin's low. Most likely it's related to iron deficiency anemia. And children who are formula fed are more likely to get iron deficiency anemia. His red cell distribution with this parameter on the full blood count called the RDW was 23. It's often elevated in children with severe iron deficiency anemia. All that means is that there are different sizes and shapes of red cells, and many small red cells, because of iron deficiency, causes hypochromic microcytic anemia with small red cells, and then there are some that are the relatively normal size. So there's a wide variation in the size of red cells, the red cell distribution, which means it's wide, and this is commonly seen. So those three things are low hemoglobin, a low MCV, and a high red cell distribution, with you would say even you don't need to measure his serum iron or anything like that. You can tell from that he's got iron deficiency anemia, and you can infer from this his low white cells, his low neutrophils, his low lymphocytes, that he's got very severe malnutrition with bone marrow suppression and may well have an infection as well. So the diagnosis that we've arrived at is severe malnutrition with complications: hypothermia, hypoglycemia, diarrhea from bottle feeding and giardia, and anemia, which is probably primarily due to iron deficiency. So therefore, we need to know how to treat Kobe, and there are some aspects of treatment that are really urgent to do to start with. And WHO has again 10 steps in 2 phases of initially of the management of severe acute malnutrition. Initial stabilization and then rehabilitation. And the stabilization phase goes for a couple of days, and it's really designed to prevent major complications of severe malnutrition that lead children to die. So many children will die from malnutrition of hypoglycemia, hypothermia, especially infection. And when children with malnutrition present, they invariably, with the severity of malnutrition of Kobe, they invariably have an intercurrent infection that's led them to deteriorate to the point that their families bring them to hospital. So the management of hypoglycemia, the management of hypothermia, management of dehydration, which Kobe also had, making sure that he's not got major electrolyte disturbance, and treating his infection. They're the key things that need to be done in the first 24 and 48 hours, very promptly in the management of children with severe malnutrition. Firstly, they're all done concurrently, so it's not like one is done and then another one is done. But firstly, the prevention of, or the treatment of hypoglycemia. In Kobe, he was hypoglycemic. So ideally, you'd give the first full feed as, now there's a formula called F75, formula 75, which is it's WHO has two formulas for children with malnutrition. There's F75 and F100. And these two formulas are ideally designed to manage different stages of malnutrition, and designed to be ideal in the and to cover many aspects, including micronutrient deficiency, electrolyte disturbance, the prevention of refeeding syndrome, which we'll talk about. So the F75 is designed to do that in the first week of management of severe malnutrition. Not every healthcare facility has F75, but if you don't, then give whatever milk formula that you have. They won't always be ideal. They may not have adequate electrolyte composition, or they might have a protein content that's a bit high and a caloric content that's a bit high to start with. Even if you still, feeding the child is the most important thing to prevent further deterioration because of hypoglycemia or hypothermia, particularly. If a child's got hypoglycemia and you can't feed the child urgently, like in the emergency department or the clinic where the child presents, then you can give 50 mils of 10% glucose down the nasogastric tubes. That's an okay thing to do. The Pocketbook of Hospital Care for Children describes how to prevent and treat hypoglycemia, and then you should start preventing hypoglycemia. Requires regular feeding. So at least every 3 hours. Some children are so unwell they need to be fed every 2 hours, just to ensure that their blood sugar remains okay and they don't get more hypothermic. So you should give feeds at least every 3 hours, at least 8 feeds a day in the first couple of days, at least, day and night. Remember, often we prescribe feeds, but children get mostly fed during the day, and they may not be fed overnight, but it's overnight that they're most prone to becoming hypothermic and hypoglycemic, and especially if they're not fed. After day 2, if the child's stabilized from that, then you need to still give at least 6 feeds a day, and especially continue ideally overnight. It's hard in busy hospitals to do this, but unless you do that, then it won't always, the outcomes won't always be as good. In terms of hypothermia, feeding the child prevents hypothermia, because the reason why children get hypothermic is, one, they get exposed often. Two, they're using up all their energy for metabolism, and they don't have enough energy to maintain their body temperature. And so if you give immediate and 3-hourly feeds, that reduces the risk of hypothermia and hypoglycemia. And you should, to prevent hypothermia, make sure that Kobe is clothed, including a hat on his head if you can, a woolen hat, and use a warm blanket, or put the child on the mother's bare chest or abdomen. Just make sure that child is as clothed as possible. During the day, that might not be an issue, but overnight, often hospitals get quite cold. So make sure the child's clothed, make sure the child's getting adequate nutrition. If they're not feeding, if they're not able to take milk well orally, then a nasogastric tube to feed them that way. This is like emergency treatment for the child with severe malnutrition. Very important. If there's dehydration, then WHO recommends a rehydration solution called Risomal, which has a lower sodium content than other oral rehydration solutions. But if you don't have Risomal, then giving ORS is good enough. Give that by a nasogastric tube, and typically we rehydrate children with severe malnutrition a bit slower than what you would rehydrate a well-nourished child. Not always. If they've got severe dehydration, you should rehydrate them promptly so that they can recover more quickly. But if they're got moderate levels of dehydration, then go a bit slower and replace the oral rehydration solution with the starter F75 so that Risomal won't protect so much against hypoglycemia, but feeding the child with F75 instead of oral rehydration solution will do that. The main thing is to start these things early and give prompt treatment for a child's hypoglycemia, hypothermia, and dehydration. Very, very important. And you can refer to the malnutrition chapter in the pocketbook for more details on that. Fourthly, electrolytes, and I it's a step in the management of severe malnutrition. If you're giving F75, there's no need to think too much about electrolytes to begin with because it has all those electrolytes in it. But if you don't have F75, then you certainly need to give extra zinc and sometimes extra potassium and sometimes extra magnesium. And ideally, any food that should be prepared should be low salt because additional salt can lead to edema in such children, fluid overload. Electrolytes are very important in children with severe malnutrition because they're more likely to get electrolyte imbalance, either to have electrolyte imbalance when they present to hospital or to get it in the often first 5 days of treatment. Electrolyte imbalance remains important for at least the first week of management, even after they're started to be fed, because there's a condition called refeeding syndrome that can lead to substantial electrolyte imbalance in the first week of treatment of severe malnutrition. So pay attention to electrolytes when the child presents and also each day, ideally afterwards. You can mitigate electrolyte impairment by giving F75 because it has those, but if not, then there's a multi-electrolyte preparation that some hospitals have that children can receive, and if not, then giving those electrolytes individually can be good. There are some foods when you start feeding that are high in these, such as bananas. Mashed bananas is quite high in potassium and magnesium, and you can give that to children, and that can help. I just wanted to touch on what refeeding syndrome is. This is just to try to explain what happens when children are severely malnourished and what happens when you start refeeding them in terms of their hormonal and electrolyte changes. I won't go through this in much detail because it's not explicitly covered in the Pocketbook of Hospital Care for Children, but just to realize that when a child's got severe malnutrition, they're in a catabolic state, which means their body is breaking down to try to maintain their metabolism. That's why they get muscle wasting. That's why they have very low subcutaneous tissue. They've lost their fat stores, for example, and the body is producing a lot of hormones that lead to the mobilization of glucose. Any glucose that a child's got in the liver gets mobilized. They get breakdown of fats, breakdown of protein in their body, and so they have loss of fat stores and muscle wasting. And because their protein levels are low, they have hypoproteinemia. They have reduced nitrogen in their body because their muscles are breaking down, and they may present they may have low glucose like Kobe did. They may have low phosphorus or phosphate, often low magnesium and low potassium because of all of these electrolyte changes. That changes dramatically in the first 24 to 48 hours after you start feeding a child. They go from a catabolic state where everything's breaking down to a state when you feed them where the body has enough nutrition to start what we call anabolism, which means they're building up protein, building up glucose stores in their liver, etc. Especially making protein. That's important, and that if you when you give a carbohydrate source, when you give a protein source and nutrition calories to a child, their insulin levels will go up. And that leads to anabolism or protein synthesis. They start making proteins again, muscle, building up muscle, etc. And it leads to glycogen storage. The glucose gets stored in the liver. Insulin drives glucose into cells. It pushes glucose into cells, but it also pushes potassium and magnesium into cells. So if a child presents with low levels of potassium, low levels of magnesium, low levels of phosphate, often it will get worse. It will get worse when you start feeding them if you're not replacing those electrolytes. And there's some other vitamins like thiamine, particularly thiamine is consumed to make protein. You need thiamine to make protein and all the proteins in the body are being made when you switched from catabolism to anabolism. And so those things those electrolytes, phosphate, potassium, magnesium, thiamine can all go lower, and they need to be replaced. I won't go through this, but it just explains these things again. The changes that occur in chronic and severe malnutrition are catabolism, right? A reduction in insulin secretion. And then once you start feeding, then a marked increase in insulin secretion, increased protein synthesis, increased glycogen synthesis, glucose gets taken up into cells, and also these other electrolytes, potassium, magnesium, phosphate, and thiamine get taken up into cells. So there's less of them in the blood. And so those things when there's less of them in the blood, then there can be consequences for other organ functions. So it can lead to arrhythmias, heart arrhythmias, low blood pressure, weakness, reduction in cardiac function, edema, and renal failure. Again, these are complications of refeeding that can be mitigated, can be minimized by the replacement of these electrolytes as part of the early few days of feeding patients with severe malnutrition. If you're not able to do that, then they're at risk of refeeding syndrome. But you should still be alert for refeeding syndrome, even if you are using F75. It certainly is part of the cause of often children come into hospital with severe malnutrition, and that the mortality is very high in the first 48 to 72 hours from these complications: hypothermia, hypoglycaemia, refeeding syndrome, and these electrolyte changes. The fifth step in the management of severe malnutrition is the management of infection. And as I said, most children with severe malnutrition, when they come to hospital, they have some infection. And you should assume that they have an infection, and if they're even moderately unwell, if they're like Kobe, severely unwell, he will have an infection. And we know he's got Giardia, but he's likely to have an infection elsewhere. So you should give all severely malnourished children broad spectrum antibiotics. So penicillin and gentamicin, or amoxicillin and gentamicin. You can look up the pocketbook for the doses on those. In Kobe's case, he also had Giardia, so he needed metronidazole, flagyl 3 times a day for 5 days. You can look that up, and tinidazole also covering for Giardia. We would also usually give an anti-helminth like albendazole, which treats hookworm infestation and other parasites. We'd also give that, and if Kobe's due vaccines, then he should have those. But very fundamentally important, the emergency treatment of children with severe malnutrition who are very unwell requires the prevention of hypothermia, hypoglycemia, electrolyte imbalance, mitigation of refeeding syndrome, treating infection. They're things that should be done very, very urgently. Micronutrients, as I said, if they're not added to the food, then you should give daily multivitamins. Give vitamin A because of the risk of vitamin A deficiency. And once gaining weight, you should start Kobe on iron, isn't it? So we knew that he was iron deficient because his hemoglobin was low, his MCV was low, his red cell distribution width was high. Very likely he's got iron deficiency. The problem is if you start iron early, then that can sometimes make infections worse. So I generally start when the child's temperature is stable, you believe their infection's under control, at least a few days after their at least a few days after that they've started on feeds and they're starting to gain weight. Usually, WHO says at 1 week you should start iron, and I think that makes sense because the infections would be treated. Step 7, which is actually one of the first steps, is to initiate feeding. I know it says step 7, but all of these things are done concurrently. That is, initiating feeding is an urgent thing that should be done in the clinic or the emergency department when a child first presents. And you should give F75, or if you don't have that, then give some other formula that you have. Give some milk formula. The ideal thing is giving 100 kilocalories per kilogram per day. You can look up the volumes and whatever in the Pocketbook of Hospital Care for Children for your child, but usually it's 130 mils per kilo per day, and that provides enough protein for the child in the early stages. F75 has a lower caloric and a lower protein intake than F100, which is the feed that the child gets started on after usually about a week after they've stabilized. Then they should be on F100, and that has a higher protein, higher calorie, higher energy intake. Their body can cope with it at that point. If they're F75 is ideally suited for initiating feeding. As I said, at least 3 hourly feeds, and ideally eight feeds a day. So 3 hourly means 8 a day, doesn't it? 24 divided by 8, divided by 3 is 8. Ideally, feeds at least 6 feeds a day, and ideally 8. Certainly feeding overnight. We've talked about this before. And if possible, continue breastfeeding. In addition, don't replace whatever breast milk the mother's got and say we'll reduce the F75. Just give the right volume, 130 mils per kilo per day, and whatever additional breastfeeding the mother has becomes very important. Once the child's started to gain weight, and remember, if a child's got edema, they're likely to lose weight to start with in the first few days or a week, and then they'll start to gain weight as anabolism takes over. That is when they start to build protein, build muscle, put back on fat, and have adequate glucose stores. Catch-up growth usually starts at 1 week, and you should start with change the starter formula F75 to F100, and in an older child who's 12 months like Kobe and older, then start on some sort of solid feeds, whether it's mashed banana or whatever you have. There are some ready-to-use therapeutic feeds that UNICEF and WHO and many hospitals make available, and they are usually high in protein, they're high in fats, and they're high caloric intake. So Plumpy Nut is one of those feeds. There are recipes on how to make up Plumpy Nut, and they can be found on the internet, and I can direct you to those. But some hospitals make up their own ready-to-use therapeutic feeds. That's important. When you're starting on the catch-up growth feed, the F100, then you should start with the same amount, the same volumes as F75 for a couple of days, so 130 mils per kilo per day for a couple of days, and then increase the feed until at least you get to 180, 200, and even up to 220 mils per kilo per day. Once the child's stable, they'll be able to cope with that. Continue breastfeeding, as I said, as part of catch-up growth. As I said, all of these steps are concurrent. You just try to do them all the time. Many children with severe malnutrition will be quite depressed. Their development is slow. They'll be quite depressed. It's not that their families don't love and care for them, it's just that their mood will be down. So you need to provide a sort of loving and friendly, stimulating environment and clearly closely involve the mother. Have toys for the child to play with or older children, books to look at and read. And when the child's well enough, then physical rehabilitation becomes very important as well. So making the environment, the hospital environment, a very sensory and stimulating environment for a child is important because they will be depressed and it will take them some time to recover. Remember, we said there's 10 stages of management of any sick child: triage, emergency treatment, taking a history, doing an examination, making a diagnosis, thinking about the differential diagnosis and comorbidities, giving treatment, and we've gone through the treatment stages in severe malnutrition, then monitoring and supportive care and discharge planning and follow-up. They're all very important, especially in children with severe malnutrition. And this was Kobe's monitoring and response chart. I've said in previous sessions that all children who are looked after who are seriously ill should be monitored with a pediatric monitoring and response chart. There are three different categories within this chart. One is the white areas, the white zones, where children have observations within the normal zone. If they're in the amber zone, that's abnormal, that's outside the normal zone, and it's concerning. And many children, when they come into hospital, start in the amber zone or the red zone because they're sick. They should improve and they should get back into the white zone. If they're going from the white zone to the red zone or white zone to the amber zone, then you should be concerned. And it's called a monitoring and response chart because there should be a response to abnormal vital sign observations. And that response should be, if a child's going into the amber zone, then rethink what's going on, rethink whether or not the treatment is right. Are all the steps being done properly? If they're going into the red zone, then they certainly need reassessment by someone who's very experienced in the management of seriously ill children or in the management of severe malnutrition. Just reassess what's going on. And you can see with Kobe, this is what happened to him. He initially, when he came in, so the chart shows his temperature, his respiratory rate, his oxygen saturation, his degree of respiratory distress, his heart rate, his blood pressure, and his AVPU score. And you can see that when he starts off, he was hypothermic, his temperature was low, and then it came up into the close to in the normal range, maybe because he got fed early and he got clothed and that sort of thing. And then it went down again. It went down to becoming hypothermic again. You can see his respiratory rate is roughly in the normal range in the white zone most of the time. His oxygen saturation was okay to start with, 92 when he came in, and then it was okay, and then it dropped down again. So we've got two things that are going in the wrong direction. He becomes hypothermic again, and his oxygen saturation drops down again. His degree of respiratory distress increased a bit into the amber zone. So three things that are not going right. His heart rate's always in the normal zone, although it has dropped, hasn't it, from 130 down to 75, which is a bit low for a child of this age. His capillary refill was all the time less than 3 seconds, and his AVPU score was okay. He was still responding to verbal commands. So something's happened to Kobe. He's become hypothermic. His oxygen levels have fallen and his degree of respiratory distress has increased. And you could imagine that perhaps if you weren't attending to all the things, if he wasn't being fed regularly, if he wasn't clothed and maintaining his temperature, then these sort of things could happen. Or if he was getting too fluid overloaded, perhaps one should think about that in terms of rehydration, then his lungs might get wetter and his oxygen saturation would get worse, or if he needed oxygen, or if he had some pneumonia that was not evident when he first came in. You've got to think about what might be going on and address those things. Monitoring and response. This child should need a proper reassessment of what's going on, and at 48 hours after treatment, think about whether or not he might have refeeding syndrome, for example. That would be something that could occur at this point in time, and then try to address that by checking his electrolytes and maybe reassessing what's going on in his lungs, because he's become hypoxic, giving him oxygen, maybe cutting back on fluid replacement if his lungs were getting wet, making sure he was on regular feeds, etc. So you should monitor for complications, and you should monitor in a systematic way, and you should have a response. So monitor for signs of heart failure, which can occur in refeeding syndrome. Monitor for signs of developing infection, hypothermia, hypoglycaemia, dehydration, and all the electrolyte abnormalities in refeeding syndrome as well. You should weigh the child the same time each day, or every second day after removing his clothes, so that you have a standard way of weighing him. Calculate his weight and plot his weight on the chart. Now, remember that children with malnutrition, especially if they've got edema, may lose weight in the first couple of days, where they're losing their edema once you start feeding. In a child with marasmus, it's less common for them to lose weight if they've just got wasting. And record his weight gain. If a child's gaining more than 10 grams per kilogram per day, that's good. That's considered good weight gain. Moderate weight gain is 5 to 10 grams per kilo per day. And poor weight gain is less than 5 grams per kilo per day. Something's going wrong. Something's not right if a child's only got moderate or poor weight gain. And you should be aiming for more than 10 grams per kilo per day. So a 6-kilo child, like Kobe was, should gain more than 6 times 10 grams times 7 for the week. If you're measuring over a week, the change in weight over a week, 6 kilos times 10 grams per day, per kilo per day. So it's 6 times 10 times 7. So he should gain 420 grams per week. An 8.5 kilo child measuring over the week should gain 509, more than 595 grams, so more than 10 kilos, 10 grams per kilo per day. You can calculate what the weight change should be over a week, and then assess over the first week whether Kobe's weight gain has been adequate or not, has been good or not. If the weight gain is poor, then you should check the following things. Is the inadequate feeding? Do we need to give more? Is it 130 mils per kilo per day may not be enough? You should observe the child feeding, and if the child's not drinking adequately, then consider a nasogastric tube to feed the child. Consider larger volumes. Is there some untreated infection, or is that would be important? Or is there some emotional or psychological problem, some psychosocial problem that you need to deal with, that maybe the child's not getting adequate feeds? It's a bit like DOTS, directly observe therapy. You should directly observe the child feeding and directly observe the milk being given, especially if you're giving it to the mother or the father, and you just want to know that they're actually getting the food that's prescribed. We said that 2 other areas that are poorly done, typically in seriously ill children, are discharge planning and follow-up. And you should be able to convey to parents what the milestones are the child should achieve before being able to go home. And so certainly for Kobe, he needed a lot of milestones to be achieved before he was safe to go home. He certainly needed to complete his antibiotic therapy for his likely infection. He should have regained his appetite and be taking all feeds regularly. And he should show good weight gain, not just over a few days, but over several weeks. He should show good weight gain, more than 70 grams per kilo per week, or more than 10 grams per kilo per day over a week, but not just over 1 week. A child like Kobe, you really should be managing him for several weeks, often because they take some time to stabilize, take some time to be sure that they're not going to get refeeding syndrome, to take time to educate his family about how better to look after him. And the carers should know before he goes home, clearly his parents were not able to look after him adequately. They were busy in their work, and they need to be available for childcare. They need to have received training on appropriate feeding and have enough resources at home to feed the child. And that may require social work input or other things. Often that's the case in such children. In terms of follow-up, all children, we said, need follow-up, but children with severe malnutrition, clearly they need follow-up. And if you're discharging a child from hospital, you should be liaising with the primary health centre or the health clinic that's closest by and making sure that they can monitor and follow the child. So you should make a plan to follow up children. The late mortality is very common in children with malnutrition, and it's usually because they're inadequately followed up. The child, Kobe should be weighed weekly, at least weekly after discharge. Even after being in hospital for several weeks, he should come back each week and have his weight taken at least weekly. And if he's not gaining weight over a 2-week period, or even if he's lost weight, he should be referred back to hospital for further inpatient care. It's not a given that he would survive, even if he has started to gain weight and reach his target weight. But it may be that he is anyway, just ongoing follow-up for these children is very important. So Kobe did gain weight well over several weeks. He regained his appetite, and his parents were, informed about feeding him at least 5 times a day and encouraged to give him his own meal, to add micronutrient supplements to each feed, to continue iron therapy for 3 months, and to monitor his appetite and his food intake. And his mum was encouraged to breastfeed him as often as Kobe wanted to, and she was given some support for breastfeeding, and weekly follow-up was arranged at the health clinic that was closest to his home. He did well after that, but it does require a lot of input, a lot of proper discharge planning, a lot of education, a lot of follow-up, and social support for such families. It's not just good enough to look after them in hospital and then imagine that they'll be okay afterwards. As I said, late mortality, post-discharge mortality is very common in children with severe malnutrition. All right, well, that's all I wanted to do, to go through the module on severe malnutrition in the Pocketbook of Hospital Care for Children, and I hope that's been useful. And there'll be other such modules posted about the different chapters in the training course in the Pocketbook of Hospital Care for Children, and I hope that's useful to you. And I wish you a good day, and take good care of your patients. All right, thanks very much.